Picture this scenario. A 71-year-old man is enjoying his retirement. His mind remains razor sharp. He still cuts his own grass every week and he still drives himself to his Tuesday night poker games. After putting it off for 2 full years, his wife finally persuades him to go in for a routine physical exam. Dr. Mandell checks him over and says, "Everything looks fine." Then the doctor adds 6 words that will alter the entire course of his life. Let's just run a few tests. Fast forward 3 months. That same man is now recovering from a medical procedure he never actually needed, for a condition that would never have caused him any harm. He is wrestling with complications that have nothing whatsoever to do with the reason he first walked into the office. And the life he had before that appointment, the lawn, the poker nights with friends, the freedom and independence, that version of his life is gone forever. This story is not unusual. In fact, this story has a specific name in medical research, and today we are going to talk about it openly and honestly. My name is Dr. Mandell. I am a physician who specializes in cardiovascular health and the aging process. What I focus on, more than anything else, is how the body's circulatory system transforms after the age of 60, and what those changes mean for the medical choices we make. In my years of working with adults over 60, I keep seeing the same troubling pattern repeat itself. People who felt completely fine when they walked into a routine appointment, but who then came out on the other side dealing with a health problem they never had before the testing process even started. That pattern has a hidden mechanism. It has a name. And once you truly understand it, you will never sit in a doctor's office the same way again. Let me give you a number that should stop you cold. Research estimates that somewhere between 15% and 25% of all medical procedures performed every year in the United States are unnecessary. But here is the part that almost nobody talks about. That percentage climbs sharply once a person passes age 65. Not because older patients are inherently sicker, but because the risk-to-benefit equation shifts completely after 65. And the medical system as it currently operates was never designed to calculate that equation properly during a rushed 15-minute office visit. There is a well-known phenomenon called the cascade effect. Here is how it works. One routine test discovers a tiny abnormality. That small finding triggers a follow-up scan. That scan then recommends a biopsy. The biopsy leads directly to a procedure, and that procedure causes a complication. Suddenly, a person who walked in feeling perfectly fine is now managing a full-blown medical situation they did not have before they agreed to that very first test. The cascade does not begin with the surgery, it begins with that first test, and that is exactly what we are going to talk about today. I am going to walk you through 5 specific medical checkups that I would personally think twice about after age 65. Not because modern medicine is broken, but because after 65, the risk-to-benefit balance changes in profound ways. And very few physicians are discussing that balance openly with their patients. I will explain why it changes, share real examples of what I have seen happen to actual patients, and then give you a list of specific questions at the end of this video that can completely transform the conversation during your next medical appointment. Please stay with me through all 5 items. Number 3 is the one that catches people most off guard because it involves a test that sounds like pure common sense. And number 1, the final one, is the checkup that almost nobody is questioning right now, even though the data behind it is more troubling than nearly anything else on this list. Before we dive in, take a moment and leave your city or state in the comments below. I genuinely read every single one, and I truly want to know who is watching this video. It means a great deal to me to see the amazing community that has grown around this channel. But first, there is one essential concept you need to understand. Without it, nothing else I say today will fully sink in. I call it the longevity lens. Here is how it works. When you are 50 years old, routine screening is often one of the best investments you can make in your health. You catch a problem early, you treat it, and you potentially gain 30 more healthy, active years. The math is simple, the investment pays off. But after age 65, three major things fundamentally change that equation. First, many of the conditions that routine screening uncovers in adults over 65 will never actually cause them any harm. Those conditions grow very slowly, they produce no symptoms, and in a significant number of cases, you will outlive them. But once an abnormal result appears on a medical report, the system does not have a leave it alone button, it has a treat it button, and that button gets pressed again and again. Second, your body's ability to tolerate medical intervention is not what it was at 50. A surgery that a 58-year-old recovers from in 2 weeks can turn into months of recovery for a 73-year-old, along with complications, loss of independence, and a quality of life that may look very different afterward. Third, there is the cascade effect I mentioned. One test, one small abnormality, one chain of events that started from a place of feeling perfectly fine. Keep that longevity lens firmly in mind as we go through every single item on this list. All right, let's jump into it, starting with number 5. Checkup number 5. Routine PSA testing after age 70 in low-risk men with no symptoms. This one requires precision because it is easy to misunderstand. I am not saying prostate cancer is not a real disease. I am not saying PSA testing has no value whatsoever. What I am saying is this: for men over 70 who have no symptoms, no family history, and no prior prostate concerns, the data on routine PSA screening tells a story that most men sitting in a doctor's office have never been told. Here is the core issue. A PSA test can detect a prostate cancer that is, biologically speaking, barely moving at all, a slow-growing tumor that if left alone would never spread, never cause symptoms, and in a 71-year-old man would almost certainly never shorten his life. He would live with it, not die from it. But the moment that PSA result comes back elevated, medicine does not wait. Biopsies are ordered, specialists are consulted, treatment options are presented, and for a 71-year-old man who is otherwise healthy, treatment for low-grade prostate cancer can mean radiation, hormone therapy, or surgery. Each of those carries real risks to bladder control, sexual function, energy levels, and overall quality of life. The American Cancer Society updated its official guidance precisely because of this problem. For men with less than a 10-year life expectancy, or for older men at average risk who have no symptoms, the risks of finding a slow-growing cancer often outweigh the potential benefits. Let me tell you about Raymond. Raymond is 74 years old, a retired electrician from Tulsa, Oklahoma. He was fit, active, had no family history of prostate cancer, and absolutely no urinary symptoms whatsoever. His routine PSA test came back slightly elevated during his annual physical. A biopsy confirmed a low-grade, slow-moving prostate cancer with a Gleason score of 6, which in medical terms means it is about as slow as prostate cancer can possibly be. His urologist recommended radiation therapy. Raymond trusted the recommendation and went ahead with treatment. Within 8 months, he was dealing with crushing fatigue that ruined his mornings, urinary urgency that changed how he lived every single day, and a quality of life that had declined in ways he never expected. When he sat down with me 1 year after treatment, the words he used were, "I felt better before they found it than I do now that they fixed it." That sentence is not rare. It appears throughout the medical literature with a consistency that should give every man over 70 serious pause before automatically agreeing to a routine PSA test. So what should you do instead? If you have urinary symptoms, hesitation, changes in urinary flow, increased frequency at night, talk to your doctor. Those symptoms matter. If you have a strong family history of prostate cancer, that changes the equation. But if you are over 70, have no symptoms, and are considered average risk, the conversation with your doctor should not be, "Should we screen?" The conversation should be, What would we actually do if we found something? And would that treatment improve my life more than simply monitoring the condition carefully? That single question alone often changes everything. Now let's move to checkup number 4. Checkup number 4, routine bone density DEXA screening followed by automatic long-term medication. Before anyone misunderstands this section, let me be clear. Osteoporosis is real. Falls can be devastating for older adults. I want to be precise here because there is a difference between questioning a test and questioning the automatic treatment pathway that too often follows that test. A DEXA scan measures bone density. If the results show low bone density, many physicians immediately prescribe a class of medications called bisphosphonates, including Fosamax, Boniva, and Actonal. You have probably seen these names in television ads. The message is simple. Low bone density equals medication, and medication equals protection. But here is what that message often leaves out. Long-term bisphosphonate use, especially beyond 5 years, has been linked to a rare but serious condition known as atypical femoral fractures. These are stress fractures of the thigh bone, the very bone the treatment is supposed to protect. These fractures can be severe, often require surgery, and in some cases, create more disability than the fracture they were originally prescribed to prevent. There is also a condition called osteonecrosis of the jaw, which involves deterioration of jawbone tissue. It can be painful, difficult to heal, and in some cases is triggered by the very medication intended to strengthen your skeleton. Meanwhile, and this is the part that should be included in every single discussion about bone health, the single most effective intervention for reducing fractures in adults over 65 is not necessarily medication at all. It is fall prevention and balance training. Research on Tai Chi in particular has shown that it can cut fall risk by nearly 50%. Removing tripping hazards from your home, installing grab bars in bathrooms, reviewing medications that might cause dizziness, having your vision checked every year, these interventions often reduce actual fracture risk more effectively than many medications, and they do so without any medication-related side effects. Let me tell you about Gloria. Gloria is 72 years old, a retired elementary school teacher from Phoenix, Arizona. After her annual physical, she had a DEXA scan and was told her bone density was below normal for her age. Her physician prescribed a bisphosphonate that very same day and advised her to keep taking it indefinitely. Gloria came to see me 3 years later after developing a persistent aching in her thigh. Further testing revealed an early atypical stress fracture. She had never experienced a fall. She had no history of fractures. She was taking medication meant to prevent fractures, and her bone was reacting badly to that very treatment. So what should you ask before automatically starting medication? Ask this. What is my actual fracture risk based on my complete health profile, not just this scan result? And can we compare the potential benefits of medication with the benefits of a structured fall prevention program? That question is neither difficult nor confrontational. Any good physician should welcome it. Now let's move to checkup number 3. Checkup number 3. Routine cardiac stress testing in people without symptoms. This is the one that surprises many people because it sounds incredibly responsible. Your doctor says, "You are 68 years old. Let's just make sure your heart is doing okay." You get on a treadmill or they give you a medication that temporarily stresses your heart while they watch how it responds. What could possibly be wrong with that? Here is the problem that almost no one discusses in the exam room. Cardiac stress tests performed on people without symptoms, no chest pain, no shortness of breath, no dizziness during exertion, can have false positive rates approaching 40% in certain populations. That means, in nearly half of those cases, the test identifies an abnormality, even though the heart is actually functioning perfectly normally. But medicine cannot simply ignore an abnormal result. That false alarm often pushes you into the next stage of the cascade, cardiac catheterization. A thin tube is threaded through your blood vessels, usually through the wrist or groin, and guided directly into your heart. The risks include bleeding, blood vessel damage, heart rhythm disturbances, and, in rare cases, the catheterization itself can trigger the very cardiac event the screening was meant to prevent. And if the catheterization finds a partial blockage, which is extremely common among adults over 65, including many who may live for decades without a single cardiac event, you may be advised to get a stent. Now, this is the part I really want you to hear. Multiple major clinical trials, including the ischemia trial, one of the largest studies of its kind, found that placing stents in patients with stable coronary artery disease did not reduce heart attacks or extend life when compared with medication and lifestyle management alone. The stent did not outperform a 30-minute daily walk combined with appropriate medical therapy. However, it carried all of the procedural risks and often required years of blood-thinning medication afterward. So the cascade often looks like this: feeling fine to routine stress test to false positive result to cardiac catheterization to stent placement to blood thinners to ongoing monitoring to no statistically significant improvement in long-term outcomes. That is the complete picture, and it all began because someone said, "Let's just check." If you are finding this information valuable, type the number 3 in the comments. It is a simple way to let me know you are following along, and it genuinely helps this channel reach more people who could benefit from this information. So what should you do instead? If you have no chest pain, no unexplained shortness of breath, and no dizziness during physical activity, the conversation with your doctor should not primarily focus on stress testing. It should focus on optimizing the factors that actually drive cardiovascular risk: blood pressure, cholesterol, blood sugar, physical activity, and sleep quality. That is where the greatest cardiovascular gains happen after age 65, and none of them require a catheterization to achieve. Now let's move to checkup number 2. Checkup number 2. Routine carotid artery ultrasound in asymptomatic patients. Almost nobody is talking about this one, and based on what the evidence shows, that silence may be one of the most significant oversights in routine senior healthcare today. A carotid artery ultrasound looks at the large blood vessels in your neck that carry blood to your brain. The idea sounds perfectly logical. Find a blockage before it causes a stroke, then surgically remove the blockage, and the problem is solved. But the reality is far more complicated, and for people without symptoms, it may be more dangerous than it sounds. Here's the fact that changes everything. The surgical procedure commonly used to treat carotid artery narrowing, called a carotid endarterectomy, carries roughly a 2% to 3% risk of causing a stroke during or immediately after the procedure. In older adults with additional health conditions, that risk may be even higher. The United States Preventive Services Task Force, the organization widely regarded as the gold standard for screening recommendations in this country, specifically advises against routine carotid artery ultrasound screening in adults who have no symptoms. Their conclusion is straightforward. For asymptomatic individuals, the risks of intervention generally outweigh the potential benefits. Here is why. A large proportion of adults over 65 have some degree of carotid artery narrowing. In many cases, that narrowing has been there for years. It remains stable, it remains silent, and it never causes any problems. But when routine screening detects it, a well-intentioned specialist may recommend fixing it. The problem is that surgery performed on a blockage that was never causing symptoms can actually dislodge a tiny fragment of plaque. That fragment may then travel directly to the brain. The intervention ends up causing the very thing it was meant to prevent. So what should you do instead? If you have no neurological symptoms, No sudden vision changes, no facial drooping, no arm weakness, no brief episodes of confusion, and no episodes of slurred speech. Routine carotid artery screening is generally not recommended and should not be your main focus. Your attention should go toward managing the factors that truly increase stroke risk: blood pressure, the most important one, blood sugar control, atrial fibrillation, if it applies to you, and maintaining consistent physical activity. However, if you experience any of the symptoms I just mentioned, even briefly, even if they disappear completely, that changes the situation entirely. Seek medical evaluation immediately. At that point, we are no longer talking about routine screening. We are talking about your body sending a warning signal that deserves urgent attention. Now we arrive at checkup number 1. Checkup number 1. Routine colonoscopy after age 75 in low-risk, asymptomatic adults. This is the one that most people have never heard challenged, because colonoscopies have been so thoroughly endorsed for so many years that questioning them in the right context can feel almost counterintuitive. But the data for adults over 75, specifically those with no symptoms, previous clean colonoscopies, and no family history of colon cancer, tells a different story than most people have heard. The United States Preventive Services Task Force explicitly recommends against routine colonoscopy screening in average-risk adults over the age of 75. Their reasoning is not vague. The risks begin to outweigh the benefits, and those risks become very real once you understand what can go wrong. A bowel perforation, a literal tear in the wall of the colon, happens in about 1 out of every 500 colonoscopies. For a younger adult, that might be a manageable surgical complication. For a 77-year-old, it can mean emergency surgery, a colostomy, a prolonged hospital stay, and a recovery process that permanently changes independence and quality of life. And that is not even counting the preparation itself. The bowel cleansing solution required before the procedure can cause dangerous dehydration, electrolyte imbalances, and major cardiovascular stress in older adults. There is also the risk associated with sedation, which increases with age, and then we come back once more to the longevity lens. The colon cancers most likely to be discovered in asymptomatic adults over 75 tend to grow slowly enough that in many cases they would never cause meaningful problems during that person's remaining lifetime. Let me tell you about Margaret. Margaret is 78 years old, a retired school teacher from rural Ohio. She had undergone 2 colonoscopies during her 50s and 60s, both completely normal. No polyps, no family history, no symptoms of any kind. Her new primary care physician reviewed her chart and told her she was due for another screening. Margaret asked questions. She was reassured that it was routine, so she agreed. The preparation hit her hard. By the next morning, she was confused, weak, and barely able to stand. Her daughter brought her to the emergency department before she ever even reached the procedure room. Her electrolyte levels were critically low, and her heart was under serious strain from dehydration. She spent 5 days in the hospital. She never actually had the colonoscopy, and the findings from those 5 days showed that her heart and kidneys had been stressed by a process intended to screen for something she almost certainly did not have. And even if she had it, she would most likely have outlived it. When Margaret called me after being discharged, she said, "I felt better when I was overdue for that test than I did after trying to take it. So what should you do instead? Ask your doctor about non-invasive stool-based screening options, such as Cologuard or an annual FIT test. These tests can identify meaningful warning signs without exposing you to the procedural risks of a colonoscopy. And if you do have symptoms, blood in the stool, unexplained changes in bowel habits, persistent abdominal pain, or unexplained weight loss, that changes the equation completely. Those symptoms deserve medical evaluation regardless of age. Now let's move to the practical advice I promised you earlier. Every time a doctor recommends a screening test, especially if you are over 65 and feeling well, I want you to have 5 questions ready. Write them down. Save them in your phone. Bring them to every single appointment. Question number 1. What is the false positive rate of this test in people my age? This tells you how likely the test is to send you down a rabbit hole of follow-up procedures even when nothing is actually wrong. Question number 2. If this test finds something, what are the realistic treatment options for someone my age and health status? Do not let the discussion stop at "we found something." Push the conversation one step further. And then what? Question number 3. What is the procedural risk of the treatment we would most likely pursue? Every procedure carries risk. You deserve to understand that risk before the procedure, not after it. Question number 4. What happens if we monitor this instead of treating it immediately? For many conditions found in older adults, watchful waiting is a legitimate and often superior approach. That is not giving up. That is making decisions based on proper risk-benefit analysis. Question number 5. What is the most effective non-invasive approach for this condition? Because as you have seen today, whether we are discussing bone health, heart health, or stroke prevention, lifestyle changes and appropriate medical management frequently outperform invasive procedures while carrying only a fraction of the risk. Any physician who genuinely has your best interests at heart will welcome these questions. They will not make you feel difficult for asking them. And if a doctor dismisses those questions or makes you feel like a problem patient simply because you asked them, that is important information about whether that physician is the right fit for you. Here is what I want you to do starting today. Before your next appointment, whether it is next week or 3 months from now, write those 5 questions on a note card or save them in the Notes app on your phone. Do it today. Bring that card with you. You may not need all 5 questions, you may only use one. But having them available changes how you enter that room, and how you enter that room can change the decisions made about your health. Try this for the next 30 days. 1 appointment, those 5 questions. And I can tell you what you will notice. By the end of those 30 days, you will feel like a different kind of patient. Not a difficult patient, a protected patient. Someone who understands why tests are being ordered, what the follow-up procedures mean, and what questions should be asked before the cascade ever begins. There is probably someone in your life, a spouse, a sibling, an adult child, or someone helping care for aging parents, who needs to hear what we discussed today before their next annual physical. You do not have to explain it all yourself. You can simply send them this video. If this conversation has changed the way you think about routine medical care after age 65, please subscribe to this channel. Next week, I will be discussing something that connects directly to everything we talked about today. Specific medications that are routinely prescribed to adults over 65 but carry a completely different risk profile at that age than they do at 50, and the questions you should ask your pharmacist before refilling them. If you take more than 2 daily medications, that video was made for you. Leave a comment below. Have you ever had a routine medical test lead somewhere you never expected? Your experience in the comments may be exactly what someone else needs to read before walking into their next appointment. Take care of yourselves. I'm Dr. Mandell, and I will see you next week.